No time for Peter, do you hear us, Peter?
Hi, yeah, I can hear you.
Can you tell us?
So we are preparing we are preparing the second case. We switched the patients, and we will introduce you now just before lunch with the next case. Stanimir Georgiev is ready to give you the PowerPoint presentation for our next case, and then you have lunch. We start with our case, and then you come back and we show what we succeeded to do so far.
All right, go ahead.
Stanimir, please.
All right, go ahead.
Cannot hear him, Peter.
Cannot hear him, Peter.
Okay, please. Better now?
No, still cannot hear him.
Can you hear me? Okay.
Can hear you, Peter, very well. So if you want to do it, whatever you want to do, but we can't hear the other person.
Okay. Can you hear me now?
No. Only can hear you very barely. Very
Is
remotely.
it better that way?
Now that's good. Go ahead.
That's good. Okay. So it's a male patient with 37 years of age with a tricuspid atresia and normally related great vessels and a pulmonary stenosis. This patient had also a Fontan-Bjork operation at the age of 11 years. He received a valveless conduit between the right atrium and the right ventricular outflow tract, resection of the obstruction in the right ventricular outflow tract, ASD and VSD closure. That was his only operation so far. He had recurrent rhythm disturbances, underwent 5 times radiofrequency ablations, and in the last year the patient is increasingly symptomatic. He has reduced exercise capacity. As you can see, the maximal oxygen consumption is 42% of normal. We did a CAT 3 months ago. These are the hemodynamics. The pressure in the pulmonary artery is low, but you can see that we have a gradient between the A wave of the right atrium and the end-diastolic pressure of the right ventricle. From about 13 millimeters of mercury, and this is how the angios look like. We have a good left ventricular function. This is the right ventricle. It's quietly nice developed. It's pumping also, and you can see this connection there to the right atrium with the free regurgitation. An angio in the IVC where you can see the dilated right atrium and again this connection to the right ventricle, which we also sized with a AGA sizing balloon, 34 millimeters with simultaneously angiography of the right coronary artery. You can see the coronary is not a problem. We measured 23 millimeters on the waist of this balloon. And our plan is now to pre-stent this region and implant a percutaneous valve. Thank you very much.
Peter?
Okay, so we prepare the patient and we'll come back. We think we will repeat the coronary angio because with the AGA sizing balloon we just desilhouette the outflow tract, but we did not give any pressure in the sagittal projection, and therefore we probably will do again the coronary angiogram and then pre-dilate with a balloon of an appropriate site. But we will inform you after your dinner, after your lunch, and then we come back together. Is
All right,
it okay?
thank you. We'll see you soon. Thank you. We'll go on to our last speaker right now.
Okay, thank you. As you all can see, we are a little behind the schedule, so...
Hello, Milano. Can you hear us? Anybody at home in Milano?
Yeah, we are here. We can hear you. So please go ahead and explain us what you were doing. Thank you.
So we will continue with our second case, which we did so far. You see here once again the Björk-Fontan drawing. Just to remind you what our what we had to do. We wanted to relieve the gradient between right atrium and right ventricular. You see these tube there implanted. This is not a tube, it is more or less a patch. And to get an impression how this morphology is really alike, we wanted to show you, because this is really an interesting case, so please concentrate. I know it's these are the last hours of the Congress, but this is really interesting. So have a look to our MRI scan. This is the MRI scan in the transversal view, and you see the right atrium and the right ventricular outflow tract and the connection in between. And the frontal border of this tiny connection between right ventricular outflow tract and right atrium is the patch the surgeon sutured over this region to make a connection between these two parts. And in this slit between right ventricular outflow tract and right atrium, so you see a black dot. This is the right coronary, so the right coronary is far away, but nevertheless, I show you the next picture. So this is the sagittal view, and the arrow indicates this oval-shaped connection between right atrium and right ventricular outflow tract. And in the first cath weeks ago, when we decided to take this case for Milano, we made this balloon sizing with the AGA balloon, and we performed coronary angiogram simultaneously, and you see how far the coronary is away. But this is, of course, an AGA balloon. So what we did now in the cath was that we tried to get this oval-shaped connection round. And I show you now in the A. Please let us go to A. To the A. Yeah, you can see the angiogram now in the A.
Yes,
I think
yes,
so.
we can see. We can see.
Yeah, you see the angiogram again, and this broad contrast regurgitation into the right atrium. So you see already a coronary catheter in place because we wanted to be sure that the coronaries are not a problem. And we did well, this was not the right one, but here you see a 6 centimeter, 30 millimeter in diameter wax balloon, and you see from a caudal, 45-degree caudal projection, how the indentation is there, where the connection is. And we wanted to do this to get around for a valve. And we injected afterwards, we did a simultaneous angiogram with the coronaries, and you see that in the lateral projection, we now need the lateral projection. Linda, can you just step aside a little bit that I can look there? So now you see the coronary completely free, and we repeated this with a little bit more indentation of the balloon, and then there was a spasm of the coronary. You see this, there was a spasm, and we thought, well, perhaps we have to wait a few minutes so that the spasm goes away. And indeed, after a few minutes, the coronary was okay. So now was the question, we have here a balloon of 26 millimeter in diameter. What should we implant here? So what would you say, how should we proceed? Any comments? Or are you all tired?
No, we are
You are
not
all tired, I see.
But we have to ask the audience, which is very small at the moment because one of the lunch session is not ended yet. Are there any suggestions? What should Peter put in there? Pre-standing or just putting in a valve? If pre-standing, which pre-stand?
Well, Ingo, do you have an idea what you would have done?
I think I would definitely pre-stand it, and I don't know, maybe in EV3 to begin with, or even 2, because it's very oval-shaped, it's directly behind the sternum, so I think you have to make it very thick, even if you are going to put in a sapien valve.
Yeah, okay. So this was our idea as well, and then we looked again for the coronaries, and then we said, well, look, this is 1.5 centimeter away, but was it really a spasm? And we repeated this angiogram with a balloon, and in the end, we came up with this situation. Look very carefully, the balloon is not still completely inflated, but what we misinterpreted as a spasm was more or less really a displacement of the catheter and a squeezing of the right coronary artery by the inflating balloon. You can see here, so that was not a spasm at all, it was the balloon which, despite there was a large distance between the right coronary artery and the balloon, there was a displacement and a squeezing of the right coronary artery. And despite, as you have seen in the MR scan, there was no calcification or other tissue which led us perhaps mislead to be that there's a scar or something like that. It seems to be relatively soft tissue. Nevertheless, there was a squeezing of the coronary, and then we stopped the procedure. So we were really astonished when we repeated this, and it was not a spasm at all. It was, in fact, a squeezing by the balloon and the transposition of the tissue in that region.
Yeah,
any thoughts to this case?
Yes, you're scaring us very much. No, we wouldn't have expected that. Or would anybody? Nobody is telling he was waiting for it. Yeah. We all thought it would be a spasm. And yeah, that's very educational. We have to be much more cautious. When I think about your first case today, what do you comment on this first case when you did the coronary while you were in the middle of the procedure?
Well, I thought the displacement was not very large because we dealt with a relatively small diameter, and we did not a tremendous displacement of the outflow tract in that case. But because we always stick to coronary angiography in and we had a new situation, we could not place the valve directly in the bioprosthesis, but we had to put it in the conduit or whatever it was behind or above the bioprosthesis. I think it was worth to do it, even if there was the coronary, there was enough space for the coronary.
Great.
No, it ended up
guys, this was
very good, but this one here is very scary, and we learned a lot from this. Thank you very much.
Yeah. Okay, thank you. I think we have now a presentation. I don't know how we proceed. We have the third